Hello, 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 everyone. Happy Saturday and welcome to a very, very, very special edition of Virtual Morning Report. Yes, we say that every time, but I hope you'll agree that having our friends from the Cleveland Clinic, who we've gotten to hang out with in various shapes or in various formats. We've actually, I see Charmina is here. Charmina and I have had the privilege of hanging out with Megan and her residents when we did a case conference there. And it's our honor to invite them here to the Virtual Morning Report community to hang out. And we haven't actually had one of these program-based virtual morning reports for a month or so. And so we're excited to reintroduce the typical format, which is that we spend a little bit of time getting to know our guests. And in full disclosure, we get to know them publicly in front of you. We I think have virtual connections on Twitter and have bridges that have linked us before, but really try to have our backroom conversation that we typically have with the CP Salvage crew out so everybody hears it. Yeah, so we'll get to know each other for a little bit, and then our friends have actually brought a case for us to discuss, and we'll use that case to nerd out as we always do, and also get to know them and their program better and how they think and how they operate and what kind of patients they see. And that's an opportunity for you, for everyone who's here, to be an active part of the conversation. I will ask you to participate in the chat, and also with time constraints in mind, also ask you to participate by sharing your thoughts out loud, if that's okay. If at any point you don't want to share your thoughts out loud, just pretend you can't unmute your mic, or just pass off the opportunity. I also see a lot of really familiar faces. Kanu, it's so nice to have you back here. It's been a long, long time. But and Jadi, wow, hello from Lebanon, a fellow Lebanese friend. It's nice to see you. All right, so I'll pass the mic to Megan to say a quick hello, and then maybe pass on the mic to her colleagues, and we'll get to know all of you a little bit better, and then jump into the case.
Awesome. So I'm Megan McGurvey. I'm one of the associate program directors at Cleveland Clinic, and we have kind of a cool conference called Clinical Reasoning Conference. So we have about 20 residents that kind of help out, and we kind of exactly like you guys nerd out on cases. So 3 of the residents are here today, 2 of which are IMGs. So that's a really cool thing that we have as well. Cleveland Clinic's definitely IMG friendly, which is, you know, a very strong, definitely a strong thing for our program. So I will let them introduce themselves.
Hi guys, I'm Brenna. I think I'm the first face on that screen. Hopefully I appear okay on the Zoom. I don't do these too often, but I am the non-IMG. I'm originally born in Indiana and grew up in Indiana, and then went to college in Miami of Ohio. Came back to Indiana for med school. So I was at IU School of Medicine, and then obviously now here at Cleveland Clinic for internal medicine. I'm a second year, so PGY2, and I'm primarily interested in cardiology and hopefully applying next year.
Brandon, that is amazing. I'm sorry, I'm going to steal from my brother Reza and interject and tell you that I've never heard somebody say I am the non-IMG. I've never heard that. I think that's such a testament to what Megan was saying earlier. So thank you for introducing yourself that way. You're also taking me back to the original days of VMR, where we try to get to know people through the paintings and stuff they have behind them. So I see a sliver of it in your Zoom screen. What do you have behind you?
Yeah, I actually got it at a street fair in Italy. And it's like a piece that I brought home, and it's one of my favorite things in my house. So I always try to have it behind me.
That's so cool. At a street fair in Italy. All right.
Yeah.
That is I'm sure that is a long story that I won't skip. I'd also I'm excited when you do get a Twitter handle, let us know. We'd love to follow you in your career in cardiology.
Yeah, so I actually just made one yesterday. Nice. Because I realized that I should definitely have one, and I'm just putting it off. So I do have one. I can put it in the group chat later.
Drop it in the chat.
Yeah, drop it in the chat.
Awesome. Yeah, we have Andrea, our social media expert, who will amplify not like no other. Alrighty, I will mute myself and let the train flow.
Yeah, I can go next. So I'm Zarar. You'll see a long name, Muhammad Zarar Khan.
I was born in Canada, grew up in Pakistan, and I've been here for the last 2.5 years. About to end my PGY3. I'm going into GI and will be starting my training at Henry Ford in July. Super excited to be here and share all my knowledge and get to know everyone and get to know what you guys think as well of our case.
Assalamu alaikum. Do you speak Urdu?
Walaikum assalam. Yes, I do.
I grew up in Lahore. Where in Pakistan did you grow up?
Lahore. That's my hometown.
Really? Where in Lahore?
Lahore. So Kent. My dad was in the military. So yeah. Well, where did you grow up?
I grew up in Johor Town. So my
nice.
My parents were worked at the International School of Shweifat. I'm not sure if you've heard of it.
No, I have. Yeah.
So my dad and my mom worked there for 15 years. So I was there from when I was 6 to when I was 18. Pakistan is home for me. All my friends are from Pakistan. And I will acknowledge, though, that my Urdu has gotten much, much, much better over the years. But the first words that I learned, I cannot repeat on the Zoom screen. So, well, actually, I could. There's nothing stopping me from. But I have very, very fond memories, and I'm excited to meet you, especially given that common ground. Welcome.
Oh, of course. Yeah, I didn't know. It's wonderful.
All right, I'll pass the mic to you, Anira.
Awesome. Thanks a bunch, Ravi. So my name's Anira. I'm also one of the third-year internal medicine residents at Cleveland Clinic. I'm actually in the VA track, which I'm going to pitch in a little bit here. It's amazing. We get to work with veterans. So my primary care clinics are at the VA here in Cleveland, which is one of the biggest VAs in the country. And so I get to work with a lot of veterans. There's like 6 people from each class that get to do that. And I'm one of the privileged ones. So a tiny little pitch in there for our VA track. But I'm originally from a small city in India. I say a small city, it still has 2 million people in it, but comparatively to Indian standards, it's called Bhopal. That's where I did my med school. I was there for 25 years of my life. And I moved here for residency. I'm going to be staying here for the next 2 years doing endocrinology at the Cleveland Clinic. So I'm very, very privileged and grateful for that. And I'm happy to answer any international medical graduate questions to reach out to me at my Twitter handle. It's very simple, Anira Iqbal MD, and just message me. But it's very difficult for medical graduates who are international to come to the US, especially in the current times with COVID and not being able to work with people in person. So I would love to help out and answer any questions that I can with this great international population that you have here. I love what you guys are doing. So big fan.
Thank you so much. Those are incredibly kind words. Yes, a small city of 2 million people. I think that seems like a paradox, but I totally understand what you mean with just the sheer volume of many cities in India. Amazing. Well, Megan, I'll let you see the ship in terms of what you had planned in terms of next steps, but it looks like it is the case. Is that right? Awesome. All right. Well, why don't we rock and roll? I did want to acknowledge that though I'm the one doing the rambling, there's actually many CP Solvers team members here, including Kirtan. I see Andrea here. I see Charmine. I see Sukriti here, and Marie, and many others that the Zoom screen is probably hiding from me. So thank you all for the tremendous work you do to make this happen. It literally would be impossible without your shoulders carrying us today. And folks, please jump on in the chat and ramble away. Well, this is a core part of what we do with the clinical reasoning here. So I'll hand the mic to Megan, and we'll share my thoughts for sure, but we'll count on you in the chat very, very heavily.
I'm the least important person in this conference, so I will totally hand it over to the residents. They've put a lot of work into this.
Beautiful. I love it.
Yeah, so we kind of broke this up into a couple different aliquots. We've got 1, 2, and 3. So all residents will take a separate aliquot. I have the first one. The first one's got a lot of information to begin with. So we kind of give you a lot of really basic stuff that most people would get when they're coming into the ED with the symptoms that this patient comes in with. So I might give you a little bit, and then obviously whenever people want to jump in and have discussion, I think that's incredible. And then we'll always have a break at the end of each aliquot to kind of have more discussion. We have a couple questions listed in case we want to talk about certain things. So I'll just start with the case. We have a 69-year-old female. She came in with shortness of breath and chest pain. She very notably had a recent hospitalization that was about 11 days long, so pretty prolonged, for acute hypoxic respiratory failure from COVID. She also was found to have bilateral PEs during the admission, started on anticoagulation, and was discharged about 8 days prior to the presentation now. She has worsening cough with a productive clear sputum at home since the admission. She uses oxygen at home that was new prior from the discharge, that she uses 2 liters with exertion. And then primarily her son was the one that was concerned and wanted her to get further evaluated, felt like she wasn't getting better from her previous hospitalization. We have some past medical history that's obviously very important for every patient. She is a diabetic and is on a pretty significant amount of insulin, hypertensive, hyperlipidemia. She does have coronary artery disease with a PCI in 2010, is on the appropriate medications for that. She has osteoarthritis in her knee, had an arthroplasty recently. And then she did have a remote history of endometrial cancer, again, kind of in remission. This is a little bit more just about the admission that was 8 days prior to her current presentation, which is, I think, helpful. She obviously came in for that admission with shortness of breath, weakness, diffuse chest pain. Ended up getting up to about 15 liters of high flow during the admission on the first day, tested positive for COVID. She remained on high flow in the ICU, got the appropriate treatment with remdesivir, dexamethasone, and baricitinib for COVID. On day 3, she had a new hemoptysis that was concerning. They got a CT and diagnosed her with the bilateral upper lobe and lingular segmental PEs. Started on heparin, transitioned to apixaban on discharge. She was also weaned off of her oxygen, did get 2 liters with exertion on home to go home, and had home nursing and therapy at home. This is just kind of a basic review of systems. I think we covered most of it, but in general, she does deny fevers, chills, and night sweats. She's just got this achy fatigue feeling. She has worsening shortness of breath and cough with the productive clear sputum that we talked about. She reports this chest pain is kind of diffuse along the chest, primarily rib pain is how she explained it. And it seemed very pleuritic on the left side. So big breaths seemed to cause worsening pain. And it was similar to her previous hospitalization. Again, not really exerting herself, so unclear to kind of see if it's exertional or non-exertional chest pain. Of note, she also does have this right shoulder pain that's new, happened about 3 days ago. Denies any falls or trauma to the area, reports that she has had arthritis in the past, obviously with the knee, and she blames her mattress at home, says it's relieved with ice. I'll give a physical exam too. So vitals are pretty normal. She's not tachycardic, normal respiratory rate, no temp. She's setting 98% on 2 liters. So I think they just put her on the amount that she gets for exertion at home. She's alert, not confused. Lungs do have mild crackles bilaterally, lower lung fields. She does have some wheezing as well throughout the lung fields. Heart exam is normal, regular in rhythm, no murmurs, rubs, gallops. Abdomen, non-remarkable, skin unremarkable. And then her shoulder does have some pain to palpation, primarily anteriorly, and she does have some decreased range of motion with flexion and abduction. Has a little bit of fullness in the area, but no erythema or skin changes there. This is her EKG. I don't know if anyone wants to try to interpret it really quickly. I can also do it as well.
You know, as a budding cardiologist, I feel like we should learn from you.
Oh no, oh no. Yeah, so I think obviously every time you go through an EKG, you want to be systematic about it. I think you look at rate first. So this looks normal rate. I would say like 80s, 90s. And then axis is also helpful, looking at 2 and AVF, looking for upwards. So it looks like it's normal axis. Then I look at just kind of intervals in particular. It looks like normal intervals, PR interval, ST interval look like normal length. The QRS also looks appropriate as well. And then looking for ST segment changes or any kind of other ischemic changes. So like Q waves or T wave inversions, et cetera. I see a couple T wave inversions in V1, V2. But other than that, that's probably old from her previous coronary artery disease. I I don't see anything else particularly concerning. Not even really any like left heart strain, right heart strain, anything like that. So I don't see anything acute.
Superb.
And then this is the X-ray. I don't know if anyone wants to read this as well. The new one obviously is the one on the left, and then on the right is from her prior admission.
I'll give it a crack. Yeah, I'm not sure. I think this X-ray is pretty tough to read, honestly, because the predominant abnormality is on the left, is on the right side, where she's experiencing her shoulder discomfort. And so my eyes were drawn away from the lungs and to see if there's anything focal in the shoulder. And I don't see any obvious fractures or marked wide joining separation. And then there's a opacification in the right hemithorax that is either pleural or parenchymal, and within parenchymal it's either filling or it is filling like pus, or it is atelectasis. And I think given the blunting of the costophrenic angle, like the complete obliteration of the costophrenic angle, I'd be most concerned for a pleural disease process, but I think the lateral would help tease out with more certainty, but more practically speaking, maybe in somebody who's getting sick before you a CT scan. I also appreciate the personal necklace sign that the patient is wearing, and would use that as a reminder to try to get to know the patient, because there's definitely a story there with that.
Yeah, it looks like almost a shell of some sort.
Yeah, I agree. That's very aquatic appearing, but who knows?
But yeah, I completely agree with the X-ray. Obviously, something's it seems to be happening in the right lower lobe. And I appreciate that you also looked at the shoulder as well, knowing that she had some shoulder pain too. I think people forget to look at the bones when they're looking at X-rays. I feel like we focus primarily on the heart and lungs when we're looking at X-rays. So it's good to look there too.
I just had to chip in here because her husband had died a couple of years earlier, but he gave her the necklace. When I asked, the first time I asked though, she goes, "I got this from a man. I'm a player, baby."
Oh my gosh.
Then it turned out it was her husband, but she was a firecracker.
Yeah.
So the necklace sign definitely there's a story.
That's so cool. Thank you for sharing. Wow.
Okay.
Do you want to? Oh no, sorry. Go ahead. The chat's on fire, by the way. This is so informative. Okay.
Yeah, and then I think we can get some basic labs, and then obviously we'll open it up and kind of talk about what we're thinking for this patient. But you can look at the white count in particular. I think is important to look at. Prior, actually, I think right before she was discharged, she still had a white count in 19 to 20 range, and here it's lower at 11.8. Hemoglobin looks stable. Platelets also not particularly concerning. And then for the general chemistry, everything looks relatively normal. I believe that's where her creatinine normally lives. Glucose is a bit high, but she has known diabetes. And the rest of her LFTs look fine as well. And then you can see she did have a high sensitivity troponin, which is what we typically do in the ED before we get the troponin Ts. And it's mildly elevated at 36. And then she's got some pretty high inflammatory markers, CRP and ESR. The prior CRP was 2.1, it's now 8.5. And then we have no prior ESR, but it's now 45. So that was obviously a lot of information, but I think given everything that you saw from what we have so far, I think the first question that most ED docs think is this sick or not sick? So do we admit this patient? And then I think a differential is like the next best thing to start talking about, thinking about, that would then guide what we order.
I absolutely love these prompts. Thank you. I think the chat has largely answered most of them, if not the you admit from the ER. But we'll definitely get to that. So, but I want to maybe after combing it through, Jenny, if you're Jenny Tobat, if you're able to unmute, there were some really excellent thoughts, and I think the first one was about shoulder pain, which I think is kind of the intriguing dimension of this case. Before we talk about what internists are comfortable talking about. So Jenny, if you're able to unmute yourself, can you tell us more about what you were thinking about with the shoulder pain?
Sorry, I was eating, so that's why my camera was off. But just with the shoulder pain and definitely this lung involvement that we are already aware of from her recent COVID and PEs, would definitely think about the shoulder pain being referred pain from the diaphragm, because the phrenic nerve that innervates the diaphragm can kind of get confused in terms of the location where the pain it's transmitting is from.
I absolutely love that. And Jenny, do you mind just telling us where you're calling from, a little bit about yourself?
I'm a family medicine resident in my 3rd year at Columbia.
Oh, amazing. Welcome. Thank you for sharing those wonderful thoughts. And my friend from Lebanon, Shadi, was sharing a little bit of a radiological differential. I'm not sure, Shadi, if you're able to unmute and tell us more.
So hello, everyone. So we see some, so the patient presented with some dyspnea and chest pain that's post-COVID, and we see blunting of the costophrenic angle and some poor pulmonary expansion. And we see like a high WBC count, if I can remember. So along with this referred shoulder pain, so we can think any acute pulmonary, and we have some pulmonary etiology, maybe an infection. We can associate any pneumonia or anything like it.
Beautiful. And where in Lebanon are you calling from, Shadi?
So yeah, I'm final year medical student at LAU. So I will be joining Cleveland Clinic as a postdoctoral research fellow next year in July.
Wonderful, wonderful.
Congratulations.
Welcome.
Thank you. Yeah, I will be in the cardiology section. So yeah.
Awesome.
That's great. Hopefully we can run into each other.
Yeah, hopefully.
This will be on YouTube, y'all, to mark your first time that you ever met, and hopefully
Yeah.
amazing.
Yeah, hopefully.
Thank you, Shadi. As we're studying the pulmonary parenchymal disease process, as we're studying the pulmonary disease process that Shadi just outlined, and merging it with the fact that the thoughts about the shoulder that Jenny shared, I think it's also important to reflect on: is there any possibility that this may be outside the lungs plus minus the shoulder? And I think that's where I missed it in the chat because the chat just keeps going on. Yeah, Kayla, do you want to unmute? You were sharing some heart hypotheses that might be related to COVID. Are you able to unmute yourself and tell us? Maybe not. I'll give Kayla another 10 seconds. Otherwise, I shall share her thought out loud, which I think is really, really important. So Kayla was highlighting the possibility that beyond the lungs to think about myocarditis, specifically from COVID or COVID-related therapies. And, you can speculate all along about vaccine-induced myocarditis, which is certainly not even close enough to be an argument against vaccination, but certainly something to entertain or know or learn or know about. And my friend Kanu, who I haven't heard from in a very long time at a busy intern year, has shared so many thoughts that I would love for a summary of his reflections so far.
Hey, yeah, so it's a very interesting case so far. I think, that just like I wasn't expecting that, especially since the patient recovered from the COVID. If I was in the ER, I would probably go with the POCUS first, just to see if the patient has an effusion and I want to tap it on the spot, send for some labs, versus if it's a consolidation and I need to send blood cultures and everything else and treat with antibiotics first. That is what I was going through.
Superb, my friend. I absolutely love it. And it's so nice to hear your voice. I know you're in the midst of a very busy year. Thank you for joining us. And Anne-Marie shared a paragraph of wisdom, and I think you should just read it. But I was wondering if you can share some of that out loud, AMK. And I also love the point about the shoulder pain, how you might tease that out between primary and secondary.
I think that here, just thinking about when someone's had a recent hospitalization, especially for COVID, thinking about how the background can help the foreground. So thinking about COVID can decrease mucociliary clearance, and so that can predispose to bacterial infections, as well as being in the hospital can predispose to more resistant organisms like Pseudomonas and MRSA. And then additionally, the patient was given immunosuppressive therapies with both baricitinib and prednisone or dexamethasone, which can also predispose to both bacterial and fungal infections. And then baricitinib is also increases clotting risk, as does COVID as well. And then if they're on steroids and have diabetes, sometimes you can get pretty hyperglycemic, which can predispose to certain bacterial and fungal infections as well. And then I also think about like which IVs, like which access did they have? Could they have seeded, gotten like a thrombophlebitis and causing like something like a MRSA infection or something like that. So those are just some of the things that I would think about considering the background.
I think that's superb, my friend. We should all follow your wisdom just blindly. And cool. And just to expand on one thing that you said, which is the fungal dimension, I think Kushal very early reminded us of the story of COVID and mucor, which is, I think, especially prominent in the press in India, and highlights the rate of COVID in patients who are given steroids, and it probably has to do with a lot of like tropical, a lot of local temperature related factors. But that's certainly something to think about. I have nothing to add to the wisdom that's coming from the chat, and we'll also just venture to extend the complications of pulmonary embolism. And one of the complications, which is rare, is that in patients, especially who have a distal pulmonary embolism, they can get a lung infarction. And so a lung infarction is certainly at play here. And the reason it's at play is because a lot of lung infarctions are vulnerable to superinfection. So it's very, very common to have somebody have a PE and they go fine, but then they can actually get infarction of the distal tissue, and that can be super infected. So a PE with infarction, given the history, is also something to entertain. Alrighty, well, we've I think, yes, admit a lot of DDX. Tests to order, I think we'll probably pass on for now, given time constraints. And I'm curious what you all are thinking about in terms of treatment. Would you?
Me too.
Yeah.
So yeah, and I think just to summarize too, I feel like I love the discussion that's happening. I think there's this thought of infection, not infection, right? With the lung findings, we have no fevers and chills. We have no increased oxygen requirements. We have a downtrending leukocytosis, which again, she had recent recent immunosuppression. So possibly that she's not mounting a strong response. And then we've got this infiltrate versus infarct versus a lot of other things that could be the X-ray. So given the clinical picture, is this someone that you start antibiotics on? And then if you do, I guess, how much coverage do you feel like is warranted?
I love it. I think there's some thoughts coming in the chat, and Sukriti's emphasizing
Yeah.
the possibility of bans, which would be really informative.
I think there's this whole debate on hospital-acquired pneumonia versus community-acquired pneumonia too. So say we are concerned for pneumonia and we decide we do want to treat, how much coverage do we want to do? Do we want to cover for Pseudomonas and MRSA? Do we not want to cover for those things, just given the recent treatments that were given, versus more thinking that since they've been out of the hospital for 8 days, is that actually needed? And also how sick the patient presents too, I think also plays into that. We can also leave those questions open too, and then go to the next aliquot and kind of see how things play out too.
You know, honestly, Brenna, I'd love to learn from you. I think those questions are actually very important questions to ask and almost impossible to answer with certainty.
Absolutely.
So I'm curious what your reflex would be in this. Like if you put yourself in the position that everyone else is in the chat, what would you be inclined to do?
Yeah, I think it's hard for me to be unbiased just because I know how this case plays out, but I do think given the information that we have presented so far, it seems like I would call this patient a pretty stable admission. They're not on increased oxygen requirement. They're not fevering out of control. We don't have a crazy white count. We do have some inflammatory markers elevated. I think this could be a patient you watch and wait. I think you can watch and see. I like to see how patients declare themselves almost. If this patient were to worsen, obviously then you start broad coverage. But if they were to improve and you could find another reason for why those inflammatory markers are elevated, or why there's maybe a consolidation looking thing in the bottom part of the lung, maybe you can wait and have it play out with more testing. So I think watch and wait would be my preference, but I don't think it's wrong to start antibiotics in this patient either.
You know, my instinct is right there with yours. I think there's really only 2 indications for empiric antibiotic therapy. Empiric meaning when you're not fully sure that your patient's infected. And those are when you're concerned that the patient has sepsis physiology and when your patient has neutropenic fever. Those are the 2 evidence-based therapies where you just throw on antibiotics and you think about it later. here, I think you're making a compelling argument that the patient's not neutropenic nor aseptic. And so you can think about it. And the thing you might do while you're thinking about it, as Mohammed is suggesting, is augment the case for infection by considering a procalcitonin. And I think, as Felipe mentioned earlier, to get thoracentesis and culture data, which might push you one way or the other.
Absolutely. Totally agree.
All right, let's hear more.
Hey guys, I'll take over from here. All excellent thought processes. Obviously in real life, the way the case is conducted, it depends a lot on your instinctive judgment when you're there in that scenario. So it'll be subjective to each and every one of you. So yeah, this is how the course progressed. The patient was started on antibiotics for hospital-acquired pneumonia given in the ED. They were held on the floor when the patient was shifted. Just cutting off a little bit here, do you guys know which antibiotics are usually started for hospital-acquired pneumonia? And in this case, which ones they would be?
You've done the DX focused chat with an RX question. I love it. Got to keep them on their toes.
Always.
Awesome. You're getting some answers.
Yeah.
Bhuti, do you want to unmute and share what your thoughts are?
I'm actually logging from my friend's laptop. My name is Shreya. So,
Hi, Shreya. Where are you calling?
I'm calling from Rochester, Minnesota.
Oh, wonderful. Awesome. Thanks for joining us. Yeah, tell us.
Yeah. Yeah. So, just like, as you asked, what is the treatment for? What is the antibiotics that will start for community-acquired pneumonia? Like from the knowledge that I have from USMLE and seeing the patients, I think antibiotics. I feel it's antibiotics. I'm not sure whether it's the right answer or not. Yeah.
Yeah, your uncertainty is reflected in many and just how many guidelines there are to how to treat community-acquired pneumonia. So don't you worry.
Yeah.
I'll pass the mic to Zara to tell you what his selection might be.
Absolutely. So, I mean, hospital-acquired pneumonia is any pneumonia that starts greater than 48 hours after hospital admission. We have to look at the risk factors that the patients have to have the hospital-acquired pneumonia. And this patient obviously was in the ICU. That's one of the biggest risk factors that we take into account when we're considering bigger bugs, which include Pseudomonas and MRSA. The third category of drugs that usually come in are gram-negative rods. They're the ones which are notorious for causing hospital-acquired pneumonia. So initially, you obviously want to see if this patient has some risks for MRSA, which could, right? Because it was in the ICU. She was in the ICU. So, Bank would be my first go-to for that. The second one, in terms of pseudomonal coverage, excellent thoughts in the chat, which say Zosyn and, obviously cefepime and ceftazidime is also something that I saw. So we can do that as well. If we're concerned about gram-negative rod coverage, then you move on to macrolides, which someone mentioned briefly as well. So just weighing out in terms of the risk factor that each and every patient have, you can sort of just narrow down your antibiotics. So continuing with the case, the patient reported worsening malaise, no fever still, and continued to experience this cough, which wasn't well controlled on supportive care, and as needed cough suppressants. And she's concerned about her breathing as well. Although her saturation continued to, she continued to be well saturated on room air to 2 liters. Her chest pain improved with Tylenol and oxycodone as needed, and ice and pain control is also helping with her shoulder pain. I love that you guys mentioned getting, thoracentesis or getting cultures. So I have some of the data for you here. In terms of the sputum smear and culture, we saw moderate gram-positive cocci, few gram-positive, rare gram-negative bacilli, and there's a growth of Klebsiella, but it was insignificant colony count, so they couldn't culture it. So nothing really on culture, just something on smear. Any thoughts when it comes to the smear results?
Yeah, I think this is a great question to ask, honestly, is what you have some gram stain and you have some culture results. What do they signify? What do they mean? Alrighty, all for the sake of time, I will ramble. I love your chosen points to stop and reflect. They're actually, ooh, you know what? Even better, we have an ID expert in the audience who just shared his thoughts. Kushal, tell us more, please.
Hi, hi everyone. So looking at the smear results, considering it's a bit of everything, I think it's probably just respiratory flora with Klebsiella colonizing, because usually we would get one particular organism or at least heavy growth if it's clinically significant.
The wisdom of Kushal cannot be matched, and I think that the concept here, if you're a first-year medical student, is to understand that there are two different places we culture. There's cultures from sterile sites and cultures from non-sterile sites. So if you get anything in the blood and you grow something in the blood, that is presumed to be a sterile site. So the pre-test probability is that that culture is significant, unless it is actually a technique issue, i.e. a contaminant that got you a false positive result. If you culture something from anywhere that is not a sterile site, so the skin, you culture people's skin, you'll find many things. And you culture people's mouths, you'll find many things. You culture people's urine, actually, you will learn that you can find many things. So whenever you look at a culture result, the first question is this a sterile site or a non-sterile site? And the general rule of thumb is the closer you are to the body's surface, the more likely it is to be a non-sterile site. So this was obtained from saliva, not a bronch. A bronch bacterial culture is much more likely to be closer to a sterile site than a surface one. And so in a non-sterile site, you rely on the amount of bacteria as a predictor, not its presence, the amount to tell you is it pathogenic or not. And the more of a single bacteria means that bacteria has taken over to become dominant, and the more likely it is to be infectious. But just because you found a small amount doesn't mean it's not causing a problem. So this is an ID doctor's nightmare. And I guarantee you, if we find nothing else in this case, you might go back and say, hey, you know what? This patient is diabetic. I know patients with diabetes are higher risk for Klebsiella, especially Klebsiella that is invasive. Do I make this, do I reconsider this? So I think Zora's question is great. The principle is it's sterile or non-sterile. Here, this is a non-sterile site. If this were a blood culture result in this patient, you probably take it much more seriously. Alrighty, back to you, my friend.
Absolutely, excellent points made. So just moving on with the shoulder pain, we did get a shoulder X-ray that wasn't too remarkable. It just showed degenerative changes. Procal was 0.11. Someone in the chat raised an excellent point with like Procal less than 0.25. So not too impressive, right? The NT-proBNP was 265. The prior one from the previous admission was 162. And the TROP-T, consistent with the EKG changes that Brenna mentioned, was unremarkable and within normal limits. Moving on, just for the sake of time, we got a chest CT, and you see two windows here, right? So we'll go from top to bottom. On the left side, you'll see the current admission, and on the right side, you'll see the prior admission. This is the upper lobe. Do you guys want to interpret?
I wonder if we should just kind of go through it and let kind of people see and then spoil it after, just for time.
Absolutely. Okay, so I'm just gonna go down. You see some of the changes here. Some you might call it ground glass, some particular changes here as well. Definitely looks to be resolving compared to the prior admission, not too remarkable, but hard to tell, have to correlate with the clinical signs. Moving on to the middle lobe, here you definitely see more ground glass opacities on the right side compared to the left, and also more on the current admission compared to the prior. And one remarkable thing that you saw in the prior admission was this dilated pulmonary artery as well. And you can tell that if you see towards extreme right of your screen, you can see it's larger than the aorta. And if we move further down, you see the opacity sort of like persisting. But here it seems like much less compared to the previous slide. And here we come down towards our airways, where we see some traction bronchiectasis, where you have these dilated airways due to an interstitial process going on within the interstitium, right? And you have these ground glass opacities as well, more towards the right side still. What did the official read actually say? So they mentioned the mild bronchiectasis in the bilateral lower lobes, extensive bilateral, peribronchial, vascular, and peripheral predominant consolidative and ground glass opacities with waxing and waning appearance, which we saw when we moved up from upper lobe to lower lobe because they weren't consistent throughout. Mild improvement in the left lung field, which was also pretty obvious from the first look, with worsening in the right upper lobe. No new pulmonary nodule, no pleural effusion, no pleural thickening, no pneumothorax. There was some mediastinal lymphadenopathy, and other lymph nodes have been mentioned as well. And there were some atherosclerotic changes in the aorta with some dilation of the pulmonary artery. Again, no pericardial effusion or thickening. So after all these testing, how did this information change your differential diagnosis? And how confident are you with your current diagnosis?
Amazing questions and a lot of really helpful data. Maybe we can pause for 30 seconds or so and see what thoughts accumulate in the chat.
Oh, sorry, just to clarify, there was no thoracentesis. There really wasn't fluid.
So I would just add that the main lesson that I took away is don't ever trust myself in reading a chest x-ray because I was so confident that there was a pleural effusion there with that blunting of that costophrenic angle. But it goes to show you that an x-ray is a very blunt instrument. And I think it's phenomenal for some things like detecting a massive pneumothorax, for evidence of heart failure with pulmonary edema and pleural effusion and cardiomegaly. But I think in this case, I don't know what that opacity is in the right chest. I don't know if that'll be answered or whether that was some atelectasis, which we often poke at our radiology colleagues for saying a lot, but it's maybe the bane of our existence in many ways. I think for the sake of time, I'll just share that this is a very hard case to solve because I don't think we know what the real problem that we're trying to solve is. We have a patient who's reporting more shortness of breath and more cough and right shoulder pain, and the pulmonary findings describe a waxing and waning ground glass opacity, which you could easily attribute to persistent COVID disease or long COVID, or the beginning of long COVID. And I think in general, the approach to ground glass opacities is no different than the approach to consolidations. Is it blood? Is it pus? Is it water? Or is it inflammation NOS? And I think that whenever you have ground glass opacities, you just prioritize two notorious infections, which are PJP, as Kushal and Anne-Marie are mentioning, and CMV. So CMV disease is notorious, but it's usually restricted to patients who are immunocompromised from solid organ transplants. So for me, I hear ground glass opacities and I'm like, oh, I have to think blood, pus, water, cells, but I prioritize PJP and viral infections, the most notorious of which would be CMV. And here, I think you have to start to think, and yes, and COVID, of course, the champion of all viral infections. And I think the question here is, how can you relate this to COVID? And I think if the case, as the chat is, sorry, I'm realizing I probably didn't teach that GGO concept with clarity. The GGOs to me means nothing different than consolidation, but then I prioritize virus and I prioritize PJP. And the viral infection that is notorious in terms of its prevalence is of course COVID, and its prevalence in terms of immunocompromised patients. It is CMV, but the list of viral infections that can devastate the lung is actually pretty long. We had a case of hantavirus that was just on the podcast. We have measles can do it, and many, many, many others. But here, I think a respiratory viral panel would certainly be helpful. Hans was alluding to the idea of maybe doing a BAL, and I think that's certainly the destination of this patient should you not get clarity. But I think as a general, sort of like trigger to think about. Whenever you hear the word migrating infiltrates in somebody who has an infection, you should think about the possibility of organizing pneumonia. So patients who have post-infectious pulmonary problems, it's a very hard diagnosis to make and may require lung biopsy, but that leaves the shoulder part completely unexplained. And so I think it probably is hard to make diagnostic progress without doing all the micro testing that you can do from the surface, like a respiratory viral panel, without proceeding down the lungs and taking a look and sampling the lungs, and or consulting Pulm and seeing what their input is on this radiology. So that's where I'd be at. There's a lot of wisdom in the chat about infections, influenza, and many other things. So take a look at it and know maybe we can get more data.
Absolutely. I just have to pose one more question. Does all this information change your current management and plan? And how are you currently treating? And before you guys answer that, I think Robbie mentioned is there one process or are there two processes going on here? We still have the cough, we still have the shoulder pain. So are you treating it the same way, conservatively, or are you treating it differently? There's some thoughts.
Very good thoughts to go into this aliquot with, because this is what we'll be answering, and I'm going to do a quick one and we're going to hit it home with this, and we'll either be very satisfied or we'll be like, why didn't we think of this? Or I was thinking of this the whole time and no one listened to me. So here we go. So this patient, once we did the initial antibiotics and then stopped it, we were observing off of antibiotics. She continued to have the same symptoms. There was really no worsening or improvement. She still felt uncomfortable. We wanted to discharge her, but she just didn't feel safe going home. She still remains on 2 liters room air, which is what she had an oxygen requirement ever since she had COVID. So we did some labs. White count, a couple of days into her admission, is now 9,000, pretty much normalized. We did repeat inflammatory markers. So ESR is significantly elevated from before. It's 111 from 45. CRP is 20.5 from 8.5 before. Repeated a chest x-ray just to see anything's changed. There was actually slight improvement of the opacity, suggested partial atelectasis with possible superimposed edema or inflammation, very nonspecific, like those radiological readings pretty much turn out to be. We did do an echo, there's a slight bump in a BNP. There are talks about COVID-induced, heart failure, all of that sort of stuff. So just to complete the workup, didn't show much. There was some septal left ventricular hypertrophy, really not significant enough to cause like a hypertrophic cardiomyopathy, pathology or physiology or anything like that. Ejection fraction was preserved. Everything else is pretty much normal, nothing new there. All right, so at this time, what is our differential? I'll give like a minute for people to answer this. So differentials given elevated inflammatory markers more than before. Leukocytosis is going down. She still feels bad. What are we doing right now? What are we thinking are our main things? And then we'll run through what actually happened. Autoimmune.
I'm curious about something. How do you guys feel about the use of inflammatory markers in this case? Was it appropriate, inappropriate? How do you interpret it?
Kushal, to answer your question, we did not get a BAL sample given that her respiratory status was pretty stable, and she was still having a cough, but it wasn't productive enough for us to go into a bronchoscopy or get a BAL sample. So we did not end up doing that. There is an inflammatory process going on. That's beautiful, Jenny. Like, that's a great thought, and that's what we're going to talk about. So Jenny says, it seems like we've looked at the lungs pretty thoroughly, and we haven't found a new source of inflammation there, so it might be time to look elsewhere. I'm seeing some more thoughts about age-adjusted ESR. on arrival was close to normal as well for her. That's beautiful, knowing that we should adjust ESR for age, as well as in females and patients with renal disease, the ESR tends to be a little more elevated and difficult to interpret. So we'll talk about that a little bit too. All right. So what eventually happened, we gave the patient gentle diuresis, see if that does anything, you know, like furosemide is always in our back pocket. Didn't do much. Her cough was still there, but significantly improved with just scheduled guaifenesin, all of those symptomatic medications. She remained on 2 liters nasal cannula and room air when she was not doing any activity. We did have the patient be evaluated by ortho because of the elevated ESR CRP. We were wondering about a joint process going here. And like Robbie had been saying from the start, we should think about the shoulder. This is what she's coming in with, you know, that's her problem. She's been having this cough and oxygen requirements since the COVID. It's not new for her, but the shoulder pain is what's really bothering her. They actually did an aspiration of the shoulder, and there was a concern for crystalline arthropathy versus septic joint. But the aspiration didn't really reveal too much fluid, so we weren't able to conduct fluid studies. We did draw cultures, and they were negative. Given the stable exam findings, she was actually treated empirically with prednisone and colchicine for crystalline arthropathy diagnosis, and her pain improved significantly. She started feeling better. She was discharged next day on room air, and on follow-up, she reported slow improvement in respiratory symptoms. So this is how the case rolled out. It's not a zebra. It's not something that, you know, is so unheard of. It's something very simple. Did you find this final diagnosis satisfying? Why not? What do you think of diagnostic uncertainty? You know, what about focusing on what the patient is coming in for, rather than subjectively what you're seeing on x-rays and an oxygen requirement and a cough that's post-COVID? What are thoughts here? And after that, I can talk a little bit about ESR CRP too and its uses. So I'll leave it open to the floor, to Robbie, to everyone else to kind of give their thoughts.
This may be one of my favorite cases we've had here. I think as people share their thoughts in the chat, I think unfortunately those listening will not have the collective wisdom of that. But I will say, I think VMR has the only thing everyone involved in VMR hopes to calibrate over the long term is the base rate of disease. And the base rate of disease means that Mucor is way more likely than CPPD on VMR, and that's not what happens in real life. And y'all are bringing to us just the best part of clinical reasoning, because the truth is that you're strengthening your clinical reasoning muscles isn't about making sure that you diagnose the case of POEM syndrome. It's that you figure out that this actually is crystalline arthritis and not some sort of respiratory issue. That's how you can, that's the real goal of augmenting your clinical reasoning. And I don't have any wisdom to share, but I will tell you that as a kid, growing up in Pakistan, I loved magic. It was just amazing to me watching these people do magic tricks. And partly because I was so obsessed with trying to figure out what they were doing. And ultimately I realized, which it may be a gross oversimplification, all they're doing is distracting you. Most of magic is having you look somewhere else while the magic is happening. And this is a magical case where all of our attention is inappropriately focused on the lung as the patient's shoulder is bothering her and bothering her and bothering her. And I think it is humbling. It's, I mean, if you reframe this case as a patient whose status post a hospitalization, who's very ill, who comes in with acute monoarticular arthritis, I mean, it's gout or pseudo gout until proven otherwise. But if you are focused on the lungs and the oxygen issue, it can be very, very distracting. And I don't think you can fault anybody for falling for a magic trick. And as is this case here, I don't think you can fault anybody for going down the pathway of prioritizing the more morbid hypothesis that this patient who has COVID PEs on heparin could be infected, has lung problems, and ultimately just in awe of how medicine is. And yes, medicine is magic. in many ways. And I think at the end of the day, no matter how smart you are, how good your knowledge is, if you're solving the wrong problem, you'll get the wrong answer. And here, I think it was very important to be focused on the lungs, but we were solving the wrong problem the whole time. And I think the only way we would have probably been led to the correct answer earlier is if we had the opportunity, which is harder and harder in modern medicine, to spend more time with the patient, be like, what's really, really, really bothering you? And I think the necklace story would have come out in more detail. And maybe the tell was actually that the necklace was over that right shoulder the whole time, telling us to focus there from the beginning. But anyway, I will pass the mic to you to take us home with your final reflections. And maybe we can also spend some time talking about your experiences in your program, if that's okay.
Yeah, we would love that. Awesome. I couldn't have put it better, Robbie, if I tried, but I would like to throw in just a quick, a minute long discussion about ESR CRP and how much it is used and how much we don't know how to use it. So we did a little bit of reading in there. And so ESR, CRP, inflammatory markers, right? ESR, erythrocyte sedimentation rate, basically is a marker of fibrinogen and how thick your blood is, to be put very simply. ESR, very non-specific, very non-sensitive too, because it can be falsely elevated with their age, with female gender, and with renal disease. But of course, greater than 100 is pretty significant. And so it's more of a chronic inflammatory marker. It has a longer half-life, stays in your blood for a long time, doesn't go down very quickly. So it's okay to be used in chronic inflammatory conditions. For acute conditions, CRP is better. C-reactive protein, it's an acute phase reactant produced by the liver in response to inflammation. So if there's cytokines present, they stimulate your liver to produce CRP. It goes up quickly within 6 hours. Its half-life is 6 hours. It goes up to its max over 2 days, and then it goes down pretty quickly too. So if you're looking for an acute inflammation, CRP is where you would put your money at. The Choose Wisely campaign, which is very well known with us, like residents, and the AFP, American Family Physician group, releases this Choose Wisely campaign. And what they say is, basically, you should not order ESR to look for any sort of acute inflammation, but they do recommend ordering CRPs to look for an acute inflammation, and then you can determine there's an inflammatory state going on, and you can follow it to see if it's worsening, if it's getting better or not. There are only 2 conditions in which you would prefer doing an ESR over a CRP. And this was interesting when I read it. So those 2 states are if there is concern for some low-grade bone and joint infection, which has just been smoldering for a while, and it's nothing acute, but it can go up and down, the ESR can. And so in that case, it's good to measure the ESR. And in autoimmune diseases, especially SLE, which is very interesting, in SLE, there is production of a type 1 interferon, which inhibits the production of CRP from your liver. So in that case, ESR is a great measure to follow for treatment and for SLE flares. So if there's an SLE flare you're concerned for, ESR, not CRP. In all other autoimmune conditions and acute infection conditions or acute inflammation depend on CRP. So here it really helped us that the inflammation was still going on and it was worsening. It wasn't getting better with all the treatment we've done. So there's something that we're missing that we're not treating, and that's what helped us focus on the shoulder. So that was my two cents on the ESR CRP. Hopefully that answers some questions, and we would love to answer anything discussed about our time here, our experience at Cleveland Clinic as well.
If that was your 2 cents, I'd be terrified what your dollar is, because oh my God, masterclass. I really, really love that. I think it's to recognize that endocrinology is your future career, not rheumatology or anything really inflammatory. Is very humbling. Thank you so much.
Thank you.
I really, really want to be respectful of your time. You're taking an hour. Everybody else, including myself, is here on our own volition, but you all are taking extra time out of your day, especially Megan, who's on service right now. And so maybe what we can do is just have each of you hit us with the highlights. Like what defines the Cleveland Clinic program for you, and what have you enjoyed the most about it, so our audience can benefit from that, and then we'll call it a day. How does that sound?
Awesome. I can go first since I'm unmuted already, but thank you for posing that question. I think I'm one of the very, very lucky ones to be able to train in a program like Cleveland Clinic. Personally, I'm from a medical school that doesn't, send a lot of people outside the country. I was one of the first people from my medical school to really step outside the country and want to train here. So Cleveland Clinic opened its arms to me and was very accepting and wanted me there. So I think that's one of our highlights of Cleveland Clinic, is they respect people from other countries who bring their expertise and their training and contribute to the program, which is one thing I love about it. I love the atmosphere here. Dr. McCurvey is one of our associate program directors, and she's available to me by text. If I want to text her at like midnight, I will be able to. So I love how reachable people are. And I love the amount of diseases that we see here, the breadth of the clinical spectrum that you see at Cleveland Clinic is on par with anywhere else that I've ever seen. So just a few things, and I could keep rattling off, but I want Brenna and Zarar to give in their thoughts too. But I think it's a great place to train at. So I'm very lucky.
Yeah, I'll echo Anira as well, just to say, I think it's the people and then the clinical exposure. So I think people-wise, the Midwest culture of how friendly everyone is was just something that I've grown up with and loved experiencing throughout residency as well. Everyone's so accommodating and supportive. And then the breadth that you would see at an institution like Cleveland Clinic, just the tertiary level of care, people getting flown in, and then the people that are coming off the street too. You see kind of a mix of everything, which is why I love the training that we get here.
I think as an IMG, it's very important to feel comfortable if you're moving, transatlantic and, you're moving overseas. It felt very comfortable and easy to me when I first, sort of started at Cleveland Clinic. And I think that's the biggest thing about Cleveland Clinic, because it doesn't make you feel like you're out of place. You have people from so many diverse backgrounds coming in, and just, everyone is bringing in their different flavors and different experiences. I cannot put it into words how great it is to learn from different people, not just, in different parts of America, but in different parts of the world. And I think that's what makes Cleveland Clinic unique, because we have such diversified population of residents and even mentors as well. And I think another thing is probably the endless opportunities that Cleveland Clinic gives you, not just in terms of fellowship, not just in terms of, obviously clinical work, but just in terms of self-growth as well. It just, brings out and shines that physician in you and that human being in you. And I think I cannot, have asked for a better experience. So yeah, just, obviously just wrapping up here, reach out to Anira, Brenna, and I, and Megan as well on Twitter. If you have any further questions, we'll be happy to answer all of those. Yeah, thank you so much for having us. And thank you so much for giving me the opportunity to come on a podcast, which I've listened to very, very intently and I'm a huge fan of. Thank you.
Oh, Megan, we have to hear from you too.
Okay. All right. Well, one, I just love our residents. That's 100% my favorite thing about working here. I think they're brilliant. They're from all over. People teach each other. It's not cutthroat. Everybody's friends. So that's definitely my favorite part, far and away. And then they let losers like me work in positions like this. So that's pretty cool too.
Anyone who publicly announces that they think they're a loser with a smile on their face is clearly an incredible human being. And, we've been very lucky, honestly, we've been very, very lucky to have so many programs come join us. But I think the CP Solvers Cleveland Clinic connection is more robust than most. And I think that just reflects the shared ground that we have. I mean, Brenna, your love for medicine was very clear from the get-go, and your enthusiasm to interpret that EKG is the reflection of the enthusiasm I think we all try to have. And I think Zarar just knows exactly when to ask great questions, even beyond the things that I'm comfortable with, like treatment questions, which I really, really appreciated. And Anira, your masterclass about ESR and CRP stands by itself. And I will just share that my impression of today is one that just reinforces the I think the widely appreciated reputation that your program has. And so I think we really, really appreciate you bringing that to our space here, and hope that we can do this on a regular frequency, hopefully next year. Thank you all, and thank you to all the CP Solvers team members who are here making it happen behind the scenes. See you all next time.
Thank you, guys.